Bismillahirrahmanirrahim. We know that the thyroid gland is very important because it secretes thyroid hormones, mainly T3 and T4, that are associated with the basal metabolic rate of the body, and thyroid gland is the target of diseases like hyperthyroidism, hypothyroidism, which explains the oversecretion and under secretion of the thyroid hormones, but thyroid hormone is also the target for some inflammatory diseases as well as uh, benign and malignant tumors. The thyroid nodule is a lump or mass of tissue that appears in the thyroid gland. The thyroid nodule may be caused by a number of disorders, and it appears in the form of a lump or mass in the thyroid gland, and mostly the thyroid nodule is formed by the abnormal growth of the thyroid follicular cells. A thyroid nodule in the thyroid gland may be of neoplastic origin or it may be of a non-neoplastic origin. The non-neoplastic or non-cancerous thyroid nodules may be caused by a nodule of the multinodular goiter. It may arise from a simple cyst which is fluid filled like sacs, and the fluid is formed as a result of liquefactive necrosis in the thyroid follicular cells. A nodule may be formed by inflammatory conditions like lymphocytic thyroiditis, granulomatous thyroiditis, which are inflammatory in origin. Now, coming to the neoplastic nodules or neoplastic growths, we divide neoplastic nodules into those that originate from benign growths and those that originate from the malignant growths of the thyroid follicular cells. The benign growths that form nodules in the thyroid gland may be follicular adenoma, and the follicular adenoma, which is a benign tumor that occurs in the thyroid gland, have differential diagnosis like multinodular goiter and sometimes the carcinoma of the thyroid. Now, coming to the malignant neoplastic growths in the thyroid gland, the malignant growths form only 1% of the thyroid nodules. By that we mean that if we have 100 patients of thyroid nodules, so 1% of them on an average will suffer from malignancy. The malignant tumors that occur in the thyroid gland, the most common one is the papillary carcinoma, which is characterized by the papillary-like projections of the follicular cells, and this is the most common one. The follicular carcinoma from the follicular cells, and the medullary carcinoma, which arises from a different set of cells known as the parafollicular or C cells that secrete calcitonin. The papillary and follicular carcinoma, they are differentiated tumors, while the medullary carcinoma arises from a different set of the cells, follicular cell, from a different set of the thyroid cells known as the parafollicular or C cells. The anaplastic carcinoma, which is a totally undifferentiated tumor, is very worst tumor that occurs in the thyroid gland with very poor prognosis, and it is usually a tumor of the old age, and it has the outcome is not very good. Sometimes a mixed pattern of tumors may occur in the thyroid gland, uh, in which papillary carcinoma or follicular carcinoma both may exist in different variations, and rarely tumors from somewhere else may get metastasized into the thyroid gland, and we put them in the metastatic tumors, for example the squamous cell carcinoma. Now, how a normal cell becomes neoplastic? We know that the cellular division is a very regulated process in which only healthy cells are in which only healthy cells are allowed to divide, and there are genes that control the cellular proliferation. The two important genes that are associated with the cell cycle and regulation of the cellular proliferation include the proto-oncogenes and the tumor suppressor genes. The proto-oncogenes normally regulate the checkpoints in the cell cycle, and they promote cell growth and proliferation, but only when it is needed. These proto-oncogenes include KRAS and BRAF genes, and at the time when cellular proliferation is needed, they will promote cell growth and proliferation. But if these proto-oncogenes become mutated, they are then known as the oncogenes. And if these oncogenes, mutated proto-oncogenes, if they persistently allow the cells to grow and proliferate, or in other words, we can say that they are persistently turned on after they get mutated. So it is one way of uncontrolled cellular proliferation. On the other hand, the tumor suppressor genes like p53, these are genes that control the cell proliferation and cell cycle, and these genes at the checkpoints of the cell cycle, they do not allow the cells with damaged DNA to divide. First of all, the DNA repairing program is initiated, and if the damaged DNA can be repaired and if the cells become healthy, they are allowed to proliferate. However, if the damage in the DNA is cannot be repaired, or if the damage is so severe, these cells undergo apoptic cell death. And this is the duty of the tumor suppressor genes, not to allow the cells with damaged DNA to divide. But if these tumor suppressor genes are mutated, they lose their ability to prevent proliferation of the cells with damaged DNA, and as a result, what happens that cells with damaged DNA or mutated DNA continue to proliferate, and the mutated cells and the cells with damage and the cells with damaged DNA, if they are allowed to proliferate, the result will be a tumor or neoplastic transformation. So the genetic mutations, particularly in the oncogenes and tumor suppressor genes, plus the environmental factors like radiation, in combination cause mutated cells to proliferate. And these mutated cells will produce abnormal proteins, and these abnormal proteins will cause excessive uncontrolled proliferation, and a cell that normally behaves the cell cycle and that is under the control of normal proto-oncogenes and tumor suppressor genes, when it is allowed to proliferate uncontrolled, we say that now the normal cell has become the neoplastic cells. Now coming to a thyroid nodule, first of all, we listen to the patient, the symptoms. For example, the patient may tell us symptoms of hyperthyroidism or hypothyroidism. For example, in hyperthyroidism, the patient may suffer from anxiety, palpitations, tremors, sweating, and we may also see the signs. Then if we physically examine the patient, we may see a mass or lump in the thyroid gland in the interior portion of the neck. Now the next step will be that if we suspect that the patient has some thyroid problem, we will advise thyroid profile, the thyroid function tests. The first blind test is the TSH, thyroid stimulating hormone, which is secreted by the anterior pituitary, and that stimulate the thyroid gland to produce the thyroid hormones, thyroxine and T3, triiodothyronine. No, so if suppose if the TSH is very high, from this we can say that since the secretion of TSH is controlled by the thyroid hormones, so when the thyroid hormone concentrations in the blood are low, they will stimulate the anterior pituitary to secrete excess TSH. And this condition favors hypothyroidism. We can say that since TSH is very high, the thyroid hormone concentrations in the blood are low. On the other hand, if the thyroid hormone secretion is high and the blood concentration of the thyroid hormones is high, it will suppress the TSH and the TSH concentration will be low. So TSH is the first line test to assess the function of the thyroid gland, followed by the measurement of the concentrations of the thyroid hormones, triiodothyronine and thyroxine. Next, we will do an ultrasound, that if there is some solid lump or mass present in the thyroid gland, or if there is fluid filled sacs or cystic nodules present, so that will become evident by the ultrasonography. Next, to ultrasonography, to further evaluate the thyroid, we do thyroid scintigraphy scanning. In this test, we give technetium and radioiodine, and we know that iodine, the function of the thyroid gland is to the uptake of iodine for the synthesis of thyroid hormones. So if we give radioiodine, the thyroid cells, after the uptake of radioiodine, then we use a specialized camera to take pictures, and this will tell us about the various abnormalities in the thyroid gland. For example, if a heart nodule that will take excess radioiodine and will appear very prominent in the scintigraphy scanning, that will tell us about the, for example, the Graves' disease, in which there is diffuse uptake of the radioiodine, and in multinodular goiter there is scattered uptake of the radioiodine. And finally, for the confirmation of our diagnosis, we will do fine needle aspiration cytology and to take a biopsy and to examine it histopathologically under the microscope to see that whether there are malignant cells or not. So the final confirmation of a thyroid disorder, mostly it will be done by the fine needle aspiration cytology and the histopathology. So this is a very important chart in which we can use the concentration of the TSH, the hormone secreted by the anterior pituitary gland, thyroid stimulating hormone that acts on the thyroid gland to cause the formation of thyroid hormones T3 and T4 thyroxine. So if we measure the concentration of plasma TSH and the concentration of free T4, and we note the two concentrations, and then by comparing the two concentrations we can evaluate various thyroid disorders. For example, suppose the TSH concentration is high. We know that when there is a deficiency of thyroid hormones in the blood, it will stimulate the anterior pituitary to cause excess secretion of TSH. If the TSH concentration is high and if the thyroid hormone concentrations in the blood is low, these two situations will indicate the hypothyroidism. On the other hand, if the TSH concentration is very low, so we know that the higher concentration of the thyroid hormones in the blood, they will suppress the anterior pituitary to decrease the secretion of the plasma TSH. So here the concentration of thyroid hormones in the blood is high and the TSH secretion as a result by the anterior pituitary is low. So this goes in favor of the primary hyperthyroidism. But additionally, in addition to free T4, the free T3 concentration will also be raised. If we have normal TSH and if we have normal free T4, this means that the patient is normal. There is no oversecretion or undersecretion of the thyroid hormones, and as a result of TSH, and this patient is euthyroid, normal thyroid. In some situations, we get TSH high, but as we expect that high TSH will be caused by the low level of the thyroid hormones, but here unexpectedly the TSH is high but the thyroid hormone concentration is also high. So this situation favor hyperpituitarism, and we can say that due to hypersecretion of TSH there is hypersecretion of the thyroid hormones. And in this situation, also the free T3 concentration will be raised, and this condition favors the hyperpituitarism, where both the hormone concentration, thyroid hormone concentration, and TSH concentration is high. In some situations, the TSH concentration is low. Here we expect that the low TSH concentration will be caused by the high level of the thyroid hormones, but here what we see that in addition to the low TSH, the concentration of thyroid hormone is also low. So in this situation we may think that there is some problem in the pituitary gland, they doesn't secrete enough TSH, and the under secretion of TSH results in low concentration of the thyroid hormones. And this situation favors the under secretion of the pituitary gland, hypopituitarism. But for the confirmation of the hypopituitarism, we have to work more workout, and to find that either the concentration of other pituitary hormone is low or normal. The two conditions known as the subclinical hypothyroidism and subclinical hyperthyroidism. Here what happens, that the TSH concentration is high, but the plasma free T4 concentration is normal. Normally, we take TSH concentration as maximum up to 5.5 milli international units per liter as the upper limit. But for making the diagnosis of overt hypothyroidism, we take the concentration of the TSH is about 10 milli international units per liter. Now, the space between the 10 and 5.5 is for the subclinical hypothyroidism. If the concentration of TSH is more than 5.5 but less than 10 milli IU per liter, in this range, in the face of a normal plasma free T4, we cannot label it as the overt hypothyroidism. But this patient with elevated TSH is potentially prone to become hypothyroid, and we label this condition as the subclinical hypothyroidism. By that we mean that an abnormality is present but there are no symptoms and the patient is apparently normal. The similar situation we can apply to the condition of subclinical hyperthyroidism, in which the TSH concentration is low but the free T4 concentration is normal. And here we can say that the normal concentration of free T4 is maintained at the cost of low TSH. And this condition is also the patient has got no symptoms but he is prone to become hyperthyroid. Additionally, the condition known as the Sikh Euthyroid syndrome. In this situation, there is no abnormality in the thyroid gland. The thyroid gland is normal, but due to some extrathyroidal diseases outside the thyroid gland in the body somewhere else, causes abnormal thyroid hormone concentrations, either because of some problems in the protein binding of the thyroid hormones. We know that the thyroid hormones are travel in the blood bound to thyroglobulin or plasma albumin and pre-albumin, and the changing concentrations of these binding proteins in various diseases can cause changes in the serum concentration of the thyroid hormones. But once the disease is over, the patient turns euthyroid. So the Sikh euthyroid syndrome is the situation which is characterized by the abnormal thyroid hormones due to problems somewhere else in the body and not in the thyroid gland, and the TSH in this situation is mostly normal. So the Sikh euthyroid syndrome describes abnormal thyroid function test in extrathyroidal diseases, and it is characterized by the mostly by low serum T4, and this will be due to an abnormality of the binding serum proteins like thyroglobulins, albumin and prealbumin, and sometimes we may get low T3 triiodothyronine concentration, and mostly due to extrathyroidal diseases. It is caused by the reduced peripheral conversion of the T4 to T3. We know that T4 is ultimately converted to T3, which is the active hormone. In these situations, the TSH level is usually normal. The patient is clinically euthyroid, and when the extrathyroidal disease is over, the thyroid function tests are turned normal. This is thyroid scanning, and we use technetium and radioiodine for in various diseases. We take images through by using a gamma camera, and we know that the radioiodine uptake by the thyroid gland in various conditions, it will be different. For example, in Graves' disease, since the thyroid gland is overactive or hyperactive, so there will be excess uptake of the radioiodine by the thyroid gland, and it will appear after we take pictures through a gamma camera, it will appear like this. In case of uh, patchy uptake, which is usually seen in multinodular goiter, we can see the patchy uptake of the radioiodine by the nodules of the multinodular goiter. Now, we say hot nodule and cool nodule. Hot nodule will be the one that will make excess uptake of the radioiodine, and it usually presents the functional or hyperfunctional unit of the thyroid gland. For example, we can see that this is an active heart nodule. But here one thing very important that I want to mention, that the heart nodules uh, usually they are not having malignant potential. Comparatively, the cool nodules are non-functional nodules in the thyroid gland. They have greater malignant potential. Moreover, in case of toxic adenoma, for example, it will appear as a single hot spot in the thyroid scanning, and we also uh, can use thyroid scanning if there is an aberrant or ectopic tissue present somewhere in the body that is producing thyroid hormones. So the tissue will also will uptake the radioiodine and will appear in the scanning. Now coming to the tumors of the thyroid gland, the as we mentioned that we divide the neoplastic conditions or the neoplastic growths or neoplastic nodules into benign and malignant. So the malignant nodules make only 1% of the thyroid nodules. Comparatively, as compared to the other growths, they are very rare, and the most common malignant tumor is the papillary carcinoma, followed by follicular carcinoma, medullary carcinoma, undifferentiated or anaplastic carcinoma, mixed tumors, and metastatic tumors. The most common benign tumor that occurs in the thyroid gland is the thyroid adenoma, and since it is caused by the follicular cells of the thyroid gland, it is known as the follicular adenoma. Now we classify the thyroid adenoma or follicular adenoma into functional, that is producing thyroid hormones, and non-functional, that is not producing thyroid hormones. So 50% are of the thyroid adenoma, they are functional, and these adenomas, they secrete thyroid hormones independent of stimulation by the TSH. and automatically this hypersecretion of the thyroid hormones will cause thyrotoxicosis. But here it is important to mention that the same situation can be caused by a toxic multinodular goiter. If a nodule in a toxic multinodular goiter become autonomous, and if it starts secreting thyroid hormones, so at this stage we must carefully differentiate between a toxic adenoma hyperfunctioning or adenoma or an adenoma that secretes thyroid hormones and a nodule of the toxic multinodular goiter. Mostly, both these conditions result from genetic mutation in the TSH receptor pathways, and as a result, the thyroid glands become autonomous. Independent of TSH, it secretes thyroid hormones, and it can lead to the hyperthyroidism or thyrotoxicosis. The non-functional or non-toxic thyroid adenoma is the one that doesn't produce thyroid hormones, and it is similar to the cord nodule because it is not functional. And as I mentioned that the cord nodules can be very dangerous because most of the times the cord nodules have high potentials of malignancy. The non-functional or non-toxic thyroid adenoma are caused by genetic mutations in the RAS and other genes, and it should be differentiated from follicular carcinoma because there is high malignant potential in the cord and non-functional nodules. In this picture, we can see the well differentiated normal looking thyroid follicles that will also appear in the benign conditions like fibroadenoma of the thyroid. And uh, since fibroadenoma is a benign lesion, it is well encapsulated and it does not invade the surrounding tissue. And we know that the difference difference between a malignant and benign growth is that a benign growth doesn't invade the surrounding tissue and it doesn't undergo metastasis, and usually the cells in the benign growth, they are more similar to the normal cells. So the presence of well-defined capsule differentiated from toxic multinodular goiter, which has not so much well-defined capsules, and the it also differentiates the uh, fibroadenoma from follicular carcinoma, since follicular carcinoma is a malignant condition and it doesn't have the well defined capsule. The sometimes the microscopic appearance of a fibroadenoma will be in the form of a Hurtl cell change. Hurtl cells are formed due to accumulation of the multiple excess accumulation of the altered mitochondria due to cells that undergo hyperplasia in fibroadenoma, and there is accumulation of altered mitochondria that gives an eosinophilic granular pink color to the cytoplasm, and this is known as the Hurtl cell change. The benign growths or fibroadenoma of the thyroid, mostly it is painless until and unless it it is so large that it compresses the trachea or the esophagus, and mostly it is discovered during a routine physical examination. And the non-functional adenoma, they appear as cord nodules or scanty scanning, and they will there will be no uptake will uh, apparent or evident uptake of the radioiodine. They do not take radioiodine, is like other functional cells on skin scanning, and unfortunately the cold nodules, they have high malignant potential as compared to the hot nodules. The toxic adenoma or functional adenoma, they appear as hot nodules, and since they secrete thyroid hormones, they will cause thyrotoxicosis. But comparatively, as compared to the cold nodules, the malignancy or follicular carcinoma in the functional adenoma is rare. So, by this, we can say that cold nodules are more prone to become malignant as compared to the hot nodules. Sometimes the mass effects may occur, and the larger adenoma or adenoma with large masses, they may compress the esophagus, causing difficulty in swallowing, and sometimes they may compress the trachea, causing difficulty in respiration. The treatment of the fibroadenoma is very effective, and when we remove the adenoma, we must send this adenoma for histopathological examination to confirm the presence or absence of the malignancy. Thank you very much.